Good evening, good afternoon, and good night, depending on where you're joining from. And welcome to our fireside chat for this evening. This is going to be our 204th fireside chat. And my name is Dr. Yuri Okech, and I'll be your moderator for this session. And the topic for this evening is going to be on renal transplantation. And the speaker is going to look at the challenging cases in low resource settings. I believe most of our participants are joining either from sub-Saharan Africa or in areas that are in low resource settings. And then he's also going to look at diagnostic and therapeutic dilemmas in this setting. And now, as I can introduce the speaker, is Dr. Arun Kumar Ponna. So he'll be taking us through this session today. And he's a consultant nephrologist at Yashoda hospitals in Somajiguda with over 10 years of experience. In terms of his educational background, he has the American Hypertension Society. He is a certified specialist by the American Hypertension Society. He's also a fellow in nephrology. He's done clinical nephrology and specifically in dialysis and transplant, also critical care nephrology and renal hypertension. And he did this in Ottawa, Canada. He has a DM nephrology from Osmania Government General Hospital in Hyderabad, India. And he did his MD, that's general medicine, in Kasturba Hospital in Manipal. In terms of experience, he's currently working as a consultant nephrology at Yashoda hospitals. He's a fellow in renal hypertension. He's a fellow also in critical care nephrology, the Heart Institute of Ottawa in Canada. He's also a fellow in clinical nephrology, dialysis and transplant, and a consultant nephrologist, as I had mentioned. In terms of his special interest, is in critical care nephrology, acute SLED and CRRT, and chronic dialysis, fluid electrolyte issues in critical care settings, glomerular diseases, complex and resistant hypertension cases, and renal transplantation. So he has a wealth of experience, as I've mentioned, over a decade, and we are really looking forward to this talk on kidney transplantation. Over to you, Dr. Arun. The floor is yours.
Yeah, thank you for the introduction, Mr. Dr. Yuri. Today, I will be talking on kidney transplant, mainly the clinical scenarios and the challenges we face in day-to-day clinical scenario, and also how we dealt with that. So we had a vast experience. We do all complex transplants in Yashoda Hospital, and last few years we have dealt with couple of many transplants where complex challenges like post-op, pre-op, and also long-term challenges. So today I will brief on the immediate post-op or before the transplant, how we got the challenges, and we can then discuss briefly. So let's see the numbers before starting the transplant case scenarios. I would like to quote the numbers. Right now, the America is having the most number of transplants, almost an annum. They do 30 to 40,000. And in India, in Asian countries like India, we do around 15,000 transplants in a year. And in Africa, most are in hundreds. So I hope this number it goes very high in next few years, and probably over thousands, and we do in 100,000s we reach in next few years all across the world. And my agenda today to mainly discuss on the donation. First, the donor fitness, how to see the donor is fit. Then the preparation of the recipient. It's very challenging sometimes during the recipient fitness. We get a lot of challenges. Today we'll be discussing that. And surgery, during surgery, surgical complications, immediate post-op complications, collections, we can discuss on that. And also the long-term graft survival, or first year of survival, where we face a lot of challenges like graft dysfunction, or like rejections, where how we suspect them, how we dealt with them. Today I'll be briefing on that, and also how the immunosuppression and the infection, how these two are important in a transplant patient. So these are the five major things I'll be concentrating on. Yeah. So let's go to the donor thing first. Like how to estimate the GFR. The first thing is when a donor comes to you, uh, how to see the whether the donor is good enough or not. And the first thing we see as a nephrologist is GFR. Here I'm not quoting a creatinine. So creatinine could be any number, but we have to estimate the GFR. And generally 60 to 90 is good, like less than 60 we contraindicate, but at least ideally we see it's above 70 in our unit. And uh, and after doing like a GFR estimation, once you get a estimated GFR, always do a second method that's confirmed using one of the method, either DTPA, or either you can do a cystatin C and combine the GFR with the EGFR, and always you repeat the creatinine and get. And the very important thing where we miss out is it has to be expressed in ml per minute per 1.73 meter square. See, if like I'll quote an example in the next slide where what is the importance of that. So if you see the GFR, a 65-year-old like came for donation. Here, whether its first question is whether the 65 years old patient can, whether he's fit for donation, whether can he donate is the first point, right? So ideally, there is no contraindication for age. The fit, if he's fit, if he's cardiac fit, and if his kidney point of view his GFR is okay, then he's fit to donate. So we have taken elderly, like we don't keep any upper age limit as a contraindication. If the family is okay and the patient, then the donor is fit, we take him for donation. If you see here, like the GFR, the patient came to me with GFR of 65.59. This is not adjusted to surface area. And ideally, when we get a donor, like most of the times, the first time DTPA could be misleading, it could be falsely high or falsely low. So when we did an estimated GFR, it was 82. But when we do a GFR, which is measured through DTPA, we got it 65, which is low. And but we again, they didn't adjust it with the body surface area. Then what I done, I've repeated the test of measured GFR. Always when there is a this correlation between eGFR and measured GFR, it's better to repeat the test, repeat your creatinine, and also repeat the measured GFR. Where after good hydration and good protein intake, when I've repeated the GFR, the estimate now the measured GFR is 92. If you see the GFR is 88, when they adjusted with the body surface area, it's 92. So initially, when the donor was a borderline, initially out when he came to me, but once again we do this test and he became a good donor. So, and the next challenges with the donation is sometimes we see, most of the time we see with the caliculi. My patients come with the donors. The donor, when you see they have mine at 7 mm caliculi, 6 mm caliculi. So whether to go ahead with this or not is the important thing. So most of the time, if there are no multiple caliculi in, or when there are no bilateral caliculi in both the kidneys, so we can tape up the case for donation. So generally here we have done a donation where the patient had 6 mm stone, 6 to 7 mm stone in the mid pole. In the same setting, we have done a URSL and we have taken for the donation. And if you see the prior slide, the patient had hypertension. And this, even with hypertension, age of 65, with no end organ damage, we have taken the kidney for donation. So the donation, like to concept, like here the emphasis mostly on the donation, where even if the comorbids are there, like if a patient is on only on one medication here and no end organ damage, they're good to donate. And pre-transplant optimization, like once you come to the recipient, the important thing is pre-transplant, like to make him fit for the transplant. And these are the four important corners where we see. First is check for the infections, check for the chronic infections, especially tuberculosis. We see in India too, like we see a lot of tuberculosis. Once they start on dialysis, the disease comes, and they have to be started. They, like most of the times, TB lymphadenitis we see a lot here. And the second important challenge is always search for the native kidney disease, whether it's a diabetic, hypertension, or any glomerular disorders. What was the cause? Sometimes we had I found a case where the patient came with renal artery stenosis. It was the patient had a stent before, up around 3 years back, on his left kidney, which was normal size. The stent got blocked, and he was initiated on dialysis at the a primary hospital. And when he came to me, I searched for the native kidney disease, where the thing is, when I saw the kidney size was okay, and the one other's right kidney was small and left kidney was good. And then when I saw what was the native kidney disease, he had an history of stenting. And when we searched for why, what happened to the stent, the stent was thrombosed when I saw did a angiogram. Then luckily what we did is, it's a thing of after 6 to 8 months of dialysis, he was anuric. We have opened up the kidney, because the kidney size was preserved, left kidney. We have opened up the kidney, and he started pouring urine, and the creatinine went down to 1.5. So from anuria, the creatinine went out to 1.5. Now she's off dialysis after she was on 8 months of dialysis. So that's a case report we are planning to do. So that's the importance of native kidney disease here, to always search for the native kidney disease, because some glomerular disorders reoccur, like a typical HOS or oxalosis. And also always search for the cardiac fitness. So the major thing is on table are immediate post transplant. The most common thing we come across is cardiac deaths. So because all first 1 month they'll be on immunosuppression, especially diabetic people, there'll be a lot of stress. So always the good cardiac evaluation is important here. And also lastly, the malignancy check. So coming to the first case, here the patient, he's a known diabetic. All complications, macro and micro complications of diabetic he had. He's a 49-year-old male. So he progressed to ESRD, and he was initiated on hemodialysis. Despite maintaining a good dry weight, he developed PND orthopnea one night, and then we have referred to a cardiologist, where because we have done a re-angio, because he already had a angioplasty. Stent was done even before starting dialysis. So we have done a re-angio suspecting cardiac cause, because there were ECG changes. Once we have done the angiogram, surprisingly the stent was stenosed. So it's very difficult to see with these kind of scenarios in dialysis, because his blood pressure was okay, his dry weight was okay. Despite that, he went into orthopnea, PND, and his stent was stenosed, and we have taken him for CABG. Once he went to CABG, what happens? Like, we all know the heart and kidney are good friends, but once the diastolic dysfunction came, and post transplant, and also the residual renal function dropped, he became anuric, and he was on almost daily dialysis because of anuric status and diastolic dysfunction. So it was challenging for us to prepare him for transplant, because every day, if he was not like, 1 day gap of dialysis would lead him to pulmonary edema. So he was so fragile. So here we have done a reduce his target weight strongly by 5 kg. So always remove fluid as much as possible. Make sure you get down to most, like, whatever very less dry weight possible. Make sure he's clinically good, and then take him for transplant. So, and the importance of robotic transplant in these patients, especially cardiac patients and obese patients, and also when patients are on dual antiplatelets. This patient was on antiplatelets, so it was challenging for us to do a transplant, because immediate bleeds and everything. So we have done a robotic transplant in him, where uh, sorry, where it tolerated well. We initiated antiplatelets very early. The wound was small, bleeding was very pretty less, drain was pretty less, and we can have an early mobilization. So after the transplant, what happened? He was diabetic, post PTCA. He was on immunosuppression, ATG, and also tacrolimus mycophenolate. As expected, he developed the infection. So it's always a challenge in transplant. Immediate post-op, like first week, we get infections, and here he developed esophageal. So here he developed a small, dysphagia and unable to swallow food, and also he has a throat pain. When we have done an upper GI scope, he had ulcers over esophagus and also patches. So it's all suspected like candida. He had a candida and HSV. So very challenging in the first week of infections, where he developed these infections. And the challenge part is once we have started on fluconazole, it has a very bad interaction with tacrolimus. We have to adjust the tacrolimus doses. That was very challenging. So we have treated here with valcyclovir and fluconazole. We have reduced the tac levels and make sure everything was okay. So this is an important slide. There is, I think, don't think so there is a transplant talk without this table. Like always, very important is infections we come across first 1 month of transplant. So there's viral infections, HSV, bacterial infections, mostly the wound infections, UTIs are pretty common, and also pneumonias. These are first, we see them in first month, and especially fungal infections and CMV we see after the first month. So early immediate post of transplants, always search for UTIs, LRTI like lung infections, respiratory infections, HSV. These are the most common in first month. And mostly after a month, you see all like opportunistic infections or fungal infections, tuberculosis in first to 6 months. And after 6 months, again the community acquired infections come into the scene. And also here important thing is cytopenias. Whenever you get a cytopenia initially post transplant, always make sure they are drug induced, like you adjust the drugs, because Septra, that is Bactrim, cotrimoxazole, valganciclovir, these are drugs which culprits which cause cytopenias in these patients. And and also mycophenolate especially. So always make sure you adjust the doses according to GFR. Stop clotrimoxazole or valganciclovir for some days if you see any cytopenias, especially immediate post transplant. And late onset cytopenia, especially after 1 month or 6 months, when you get cytopenias, again, if you don't feel any drug induced, always suspect CME, especially if they have fever and malaise. So make sure you don't miss out the CMV and send for a CMV titer there. And especially if they have diarrhea or viral infections or ophthalmic infections, always suspect CMV infections. And also if they have GI persistent diarrhea, also suspect EBV infections and do a biopsy in them. And also don't miss out if they have diarrhea, especially long-term diarrhea. Don't miss out on MMF causing diarrheas. Before the infective, MMF causing diarrhea is pretty common, and always change it to mycophenolate sodium, which helps out in reducing the diarrhea. And here the important thing is like coming to post transplant. So here we optimize the pre-transplant. We have seen how we optimize the pre-transplant, and now after going to transplant, what to expect after post-transplant. So graft function, what are the most common causes of graft dysfunction post transplant? One is pre-renal. Always check for the weight loss and low BP pre-renal, and also adjust the tacrolimus level. So these are the most common graft function causes post transplant. These four things you have to be in mind. First is pre-renal cause, volume. Second, always tac. Check for the tac levels. See any signs of tac toxicity like hypertension, hyperkalemia. Make sure see whether they are fluid responsive. That gives a hint it could be tac toxicity. And also always search for the infection. This is the most common cause of graft dysfunction post transplant. Again, the last one is rejection. So any graft dysfunction post transplant, these four things you have to be in mind, that is pre-renal, tac, infection, and rejection. So coming to the brief of those, we'll go into the case 2, where early AKI post, like post transplant, early within 5 days, we have seen a case where he was discharged with good graft function, creatinine 9.9 on the POD5. The patient went home. After 5 days, he came back for review, and the creatinine was 1.4. Here, if you see the weight is down, it's a clear indication that it could be volume depletion. And see, CUE is totally normal, so we didn't see any urine and pus cells in the urine again. So we ruled out urinary infection here. And always do a post transplant ultrasound. Once you see a creatinine, once you see a urine analysis, then go for an ultrasound. Keep it a regular approach of these cases, and make sure there is no obstruction. Once this is done, okay, then make sure, like, then go for, think about pre-renal causes. Always first thing, common things occur commonly. Always search for the pre-renal causes, hydrate them, adjust the tac value, and most of the time they will be responsive. Because in this scenario of ATG and good immunosuppression, we hardly see rejections. So immediate post transplant, most common reasons are still the pre-renal. Always search for the infection, obstruction, and if they are fluid responsive, that's a very good. Most of the time they'll be fluid responsive and adjust the TAC levels. And in this scenario also, it's clearly a pre-renal. And this timely, just a clinical approach of this, we avoided a kidney biopsy on him, and creatinine improved immediately after the iteration. And coming to the second case, how we approached this. So these are all like graft dysfunctions, how we approached. For example, this patient, he is a 20-year-old male, native kidney disease, again very important viewer. And but before the surgery, he never had, before the transplant, he never had urinary infections. So we didn't do any native kidney nephrectomy here. Generally, our protocol is, if they had any urinary tract infections recurrent, then we take him for native kidney nephrectomy, then we take him for transplant. But here he never had any UTIs in childhood, so we have taken him for transplant. Mother is a donor. He had a very good graft function immediate post transplant. But after 10 days of transplant, surprisingly, he had a UTI and his creatinine graft dysfunction. So, and he has a loin pain. So we thought of pyelonephritis. We have done a CT where we have suggested of pyelonephritis. Culture has grown MDR Klebsiella. We have treated with meropenem. He got better, but the thing is, he came again 4 weeks later with the same sign, loin pain, and again a relapse of UTI. And now the bug was only sensitive to colistin. It was a MDR Klebsiella. And like we have done a given a colistin for some days, but even after giving colistin, the the graft dysfunction and UTS were recurring at every 4 will, like this creatinine was creeping slowly up, and he had an recurrent episodes of infection. So ultimately we have done, what we have decided is, we have to remove, because he was having more on the loin pain rather than the graft pain. So we thought these native kidneys are the culprit, and we have done a native kidney nephrectomy one by one. Bilateral stage native kidney nephrectomy we have done. After course, now is after that, after 6 months after all these things, his creatinine stabilized at 1.5 and he never had UTIs. So we have adjusted the microfinillate doses, we have reduced a little, and we have reduced the TAC level. We have taken him for surgeries. One month first we have taken for left, then after 4 weeks we have taken him for right. And after the surgeries, his UTI subsided and graft function stabilized. But surprisingly, once after 6 months after of nephrectomy, or 3 to 6 months, I didn't remember the timeline, but probably 3 months of the nephrectomy, he had a graft dysfunction. So he never. But again, he's using. We have followed the same approach, like CUE, ultrasound, and if you see, his CUE was totally normal. His culture was negative. I Then ultrasound was normal, and we have given a fluid challenge, but he didn't. The creatinine started creeping up, 1.5, 2.1, 2.3. So we have seeing at the rising trend of creatinine. We have done a kidney biopsy, and it was rejection, cellular rejection, and we have treated it. Now the for last few years, yes, creatinine is stabilized at 1.6, 1.7. For last 3 years, it stays there. So the graft dysfunction post transplant, always like most of the time, ACR, we think first rejection. And always after few months of transplant, once the early go for early post transplant, think about pre-renal causes. After few months, or once the kidney is stabilized, if the graft function is there and if the creatinine is trending up, always think about rejection. And most of the time, surprising thing is, you don't see any proteinuria or urinary signs in rejection. Most of the time you see bland urine. And you could have a worsening hypertension there. So always if the creatinine trend is going up, once you rule out other causes, make sure you do a biopsy and pick up the rejection. But not in all scenarios. Go with the same approach, like initially is urine, then evaluate fully, get an ultrasound, fluid challenge, and adjust the TAC level. If still the creatinine is worsening, then do a biopsy, and mostly it will be rejection. So Case 3, where transplant in the setting of a TB and tumor. It's again a challenging case. 49-year-old male with morbid obesity. So he was obese. I'm sorry. He was obese, above 100 kg, and he had faced a lot of challenges. Preparing him for the transplant is a big thing, because he had a cardiac tamponade, mediastinal lymphadenopathy. We have done EBUS in him, and we picked up TB, and he was also HCV positive. We have treated HCV for 3 months, and we have treated him for TB and HCV. After 6 months, once we planned for transplant after completion of TB treatment, surprisingly, what happened? He developed a nodule over his thigh, and we thought initially an abscess, but when we examined it, was more of an hard mass, and we have taken him for surgery. And we have done a wide excision on him and sent it for pathology. It was showing a low grade myxo-inflammatory sarcoma, which is a very rare in dialysis patients. But whether to take him for transplant or not is a question here. He had a low grade myxo-inflammatory tumor, and it's a low grade sarcoma. Surprisingly, PET scan didn't show any spread. And after taking the oncology opinion, because it's a low grade tumor, we have taken it for transplant. So decision making dilemma: TB prior, then again soft tissue sarcoma, can we transplant? So always do a team decision, discuss with the subspecialist, and because here it's a PET negative, after wide excision we have taken it for transplant. The post transplant challenge: the same patient had a wife was the donor, he had a transplant. After that, he had a laceration to the kidney. So interhop, this is a challenge. Sometimes surgeons gives you surprises, right? Like we had an interhop laceration to the kidney. He had an hypotension shock, and and he had a blood loss and hypotension. So we had a low graft function here. The graft was not functioning well, and the creatinine was creeping. It was the trending down was very slow. The urine output was very low. So it was a very challenge. The graft function was poor. He had an hypotension, blood loss, and graft function was low. So, but he didn't need a dialysis here. So the possibilities are graft ischemia, ATN, surgical causes like it could be obstruction due to the hematoma there, or immunological causes like rejection. But here we followed again the simple approach. We didn't get panic here. So go with the same approach here. So always send a simple urine examination. Probably here you will find definitely an hematuria. So the thing is, the creatinine was slowly trending down, improving urine output was there. We have done an ultrasound where we didn't find any obstruction, and also look for the gradual improvement. If the kidney function is gradually improving, mostly it's an ATN, so ATN is recovering. If the graft function is worsening, do a re-imaging. If we don't find any obstruction, always do a kidney biopsy. In this scenario, always give judicially urine IV fluids, because the graft function was a little slow. And so always give fluids judicially. Don't overload him, because urine output is with little marginal. Make sure he's euvolemic, and always if the creatinine is worsening, just go for a biopsy. But in this scenario, the creatinine was slowly trending down, urine output was gradually improving. And the important immunosuppression thing is, whenever you have a slow graft function or delayed graft function, make sure you hold the tag and give ATG in him. Okay, so ATG, make sure you give ATG. Uh, Slow graft function, make sure you avoid tag in the settings. Function started getting better, you can restart the tag. So here one more case, like where we had a challenging case. So here where we had an like bad hypertension, resistant hypertension case. He came up to me for the kidney transplant, and uh, when we have done a like it was when we have done a search for the kidney biopsy, priorly he had, it was more of a TMA. So here the question is whether to do a transplant or not in a TMA case, because he had a malignant hypertension, nephrotic rich proteinuria, CKD, Biopsy was more of a TMA, and there were no immune deposits. Whether to take him for transplant or not is the question. So we have evaluated him fully. We have done a complement levels. ANA was negative, complements were normal. There were no cystocytes, no immune deposits on IF, and we were done. We have done a genetic testing which was negative. So we thought, secondly, this is mainly due to malignant hypertension associated TMA, as there were no signs suggestive of immune mediated or genetic TMA, and we have taken him for transplant. So the thing is, one confident where we were like very sure of taking him for transplant was, uh, he had a good response to aldactone on dialysis. He had a resistant hypertension on dialysis too. So where we had a confidence on taking him for transplant is his resistant hypertension got better on aldactone when he was on dialysis. When we started on spironolactone, he had a marked improvement in BP control. This gave a clue that this could be underlying hyperaldosteronism, and we have taken him for transplant. So post-transplant, again, the challenge is he had a slow graft function. So initially, we didn't start him on aldactone. His blood pressure was good for first 3 to 4 days, and after 3 to 4 days he started developing graft dysfunction. So here the point, we thought whether the HUS came back, we thought whether we missed the primary HUS, and we got misled by hyperaldosteronism. Then we have searched the smear. There were no cystocytes, no cytopenias. Complements we have done repeated, they were normal, and LDH was normal, haptoglobin was normal. So it was not fitting into fully TMA. So what I've done, as he responded well with the aldactone, I have restarted him on aldactone. Surprisingly, his graft function improved, and hypertension improved. There is a challenges always in when you get a TMA. So always, when you, it's very important to see the native kidney disease and make sure you evaluate them fully. And most important pre-transplant reoccurrences are TMA and FSGS. When these two cases are there, always get a genetic analysis. FSGS especially, make sure whether it's a primary FSGS or secondary FSGS. So because primary FSGS, it might recur uh, quite faster. Even early post-transplant, you can see proteinuria around recurrence is about 30 to 50%. So these are the two diseases you have to be very careful when you get as a native kidney disease. And coming to the immediate post-transplant drainage, like collections, most of the time when you get a high drain output, always check for the urine creatinine. Make sure, just rule out the urine leaks here, but most of the time this could be just a volume overload or the serous fluid they coming out. And after a week, if you see any collections, it's mostly lymphocytes. And always follow a conservative approach. Rule out urinoma in them too when you have an collections. And always make sure immediate post transplant, be careful about hematomas. Get an immediate post doppler once you do a transplant. Once the patient comes of 40, the same day you do a doppler. Make sure there are no collections. And if you have a collection, and if the hemodynamics are worsening, always repeat the hemoglobin and repeat the doppler. And I'm sure we had a case where immediate the same day the BP was falling, we had a small hematoma. On the repeat scan, the hematoma became big and the hemoglobin dropped. Immediately we have taken him for exploration, and luckily we saved him. So otherwise, there are instances where we missed out hematomas and bleeds, and they landed up in hemorrhagic shocks and very bad scenarios. So the transplants, why we despite all this, why we suggest them for transplants. Like dialysis patients have a very good quality of life. Live transplant have almost more than 90, whereas 5 year survival of a dialysis patient is 33%, but it's around 88% in a live transplant. So despite all challenging cases, clinical acumen is important key here. Like just hold on to the case, just go with the basics, blood pressure, make sure just get a simple urine test, ultrasound, and just follow the approach. If the So with good clinical acumen, you can always succeed in a transplant. And always the takeaway points is donor age is not a chronic contraindication. If it metabolic diseases, type 2 diabetes, hypertension, if no target organ damage, you can take depending on the risk benefit ratio. Graft dysfunction, not always it's rejection, so always rule out pre-renal infective causes and obstructive causes. If the creatinine is not trending up, just hold on, set a tack level and adjust it. But if the graft of a dysfunction, the creatinine trend is going up, always do a biopsy. I'm sorry. And high risk cases, cardiac cases, chronic infections, malignancies, always follow a multi-team approach. And be aware of collections, especially motomas post immediate transplant. Be aware of collections. Make sure these you deal very cautiously with, especially with hematomas. Yeah, thank you. Any questions? I'm happy to take questions. We can discuss more. Yeah.
Thank you so much, Dr. Arun. That was quite an enlightening discussion, and also very nice and challenging cases. I think it was very good to learn from the cases and how you are able to resolve the issues that came. And I know some in our setups, it's still a bit of challenge in terms of working up patients, in terms of affording the tests, and also, being in a setup that has capacity to do them. But quite an enlightening discussion. I think there are very many cases to learn from and very different scenarios there. At this time, I just want to open the floor to any questions. For the participants, you can use the raise hand feature if you want to speak, or you can just type your questions on the chat box and then I'll read them over to Dr. Aaron. Oh, sorry, there's one question on the group. I think it's from, I believe this is one of our clinicians by the name of Theresa. The question is on, I think she's asking, are patients with autoimmune conditions fit for kidney transplant?
Yeah, it's a good question.
Um,
Uh, Especially like we do transplants in autoimmune, especially we see a lot of lupus in India. We see a lot of AGA, IgA nephropathy, lupus, and ANCAs. We take them for kidney transplants. There is no contraindication. Only thing is if you have get a ANCA vasculitis or anti-GBM antibodies, we make sure like the antibodies are negative for at least 6 months. And otherwise and when ANA is there, like autoimmune disease, we make sure the kidney disease in remission. That's it. Yeah. In case of rejection due to circumstances, what is the best way to handle? Can the patient be considered for under transplant? See, most of the time rejections, like if you catch them early, it's we can reverse them. Okay, especially cellular rejections, we can give them steroids, or if there are they're not responding steroids, you can try ATG. And autoimmune, if it is an autoimmune rejection, you can try plasma exchanges. So most of the time, if you catch the rejection early, there is a very good possibility that rejection might come back, like the kidney graft function might come back to at least good capacity. But if you miss out early rejections, then it's little difficult. So that's all depend to case scenario. So resistant rejections, not responding to well treatment, then they might land up in having a second transplant. But otherwise, like always, these are all high risk. Why? Because you have to search for why he had so much of bad rejection, whether and also while taking him for second transplant, you have to see for sensitization, what is his DSA is there. So always in this scenario, second transplant is a little challenging when you had a bad rejection. But if it is due to non-compliance of medications or some other reasons like that, then I think that's a good you can easily take it for second transplant.
Thank you for that response. I think the last bit of your response is a big challenge. I know there are patients who default because of the high cost of post-transplant medications afterwards. So I think also for them to be economically well positioned before you decide to, of course, do another transplant, because you don't want another challenge again after the second transplant or subsequent transplants. Thank you for that question, Patrick. I'm sure your question was well answered.
Uh,
Um, yes,
Hi,
Dr.
Arun.
Lloyd.
It's a lovely presentation. Thank you very much for that excellent overview of issues and evaluation of donor, the issues you find in transplant, and some of the unique situations that you've handled so well, and the technology that you use in terms of robotic kidney transplants. So can tell us something about robotic kidney donor nephrectomies and kidney and recipient side, on both on the donor and recipient side. That will be very interesting for us. The second question is, you would have seen a lot of patients from Africa. So what are the common issues that you find in patients from Africa that you've dealt with, or both usual and abnormal situations, if you can remember? So, but I think the first is the technology that you use, robotic, transplants that you do. Yeah, on the recipient side, the donor, yes, or even donor and recipient, both you can actually, that would be great, actually.
Yeah. See, I can just, if I'll try to put in a video, if possible, just to give. And the one thing is, donor, we just do laparoscopic. It's nothing special in donor. So, robotic, mostly, a robo sits with the recipient.
Okay, great, wonderful, thank you.
And the pop, and what a recipient, what we do is we put a laparoscopic ports, and we put a robo inside the like the peritoneum, and we pierce the peritoneum, and we do the surgery from inside. So that's a
Yeah,
quite interesting surgery.
okay,
So we put the ports as a laparoscopic ports, same like laparoscopic ports. We put the ports, and through the
yeah,
ports we cut the peritoneum from inside, and then
yeah,
we do the surgery. So here,
oh,
especially in normal surgeries like transplant surgeries, we don't cut the peritoneum. We put the kidney extra peritoneum, right? So
oh,
here we
yeah,
cut the peritoneum. Through the peritoneum, we access the kidney, like we go into the extra peritoneum, then the
okay,
kidney in from the outside, and then from inside you stitch it into the external iliac arteries. After the
okay,
stitch done, then you again stitch the peritoneum. So it's a like, and you see very detailing of the detailing of the external iliac, and the anastomosis is very minute detailing you will see. The anastomosis is
mhm,
very precise anastomosis you get, and the bleeding is very less. So I was there in the surgery all through when the robotic was going on. Actually, I have the videos. I'll share with the videos with you. You can share in the group. So
yeah,
it's very. I was surprised to see the robotic transplant, because
yeah,
you can see the anastomosis so clear, like the minute anastomosis. You can just see like so clearly and so magnified, and
yeah.
hardly you see any complications like leaks or any stenosis, something like that.
Okay, and this is the Da Vinci, the same that is used, the Da Vinci robot?
Yeah, Da Vinci robot, Da Vinci robot.
Da Vinci robot. Okay,
We
okay,
have
good,
done a
good.
transplant on a Tanzanian patient, one patient, robotic kidney transplant. So he came
Uh-huh.
here. He came here with a lady stenosis.
Mhm.
Also, he had a subclavian stenosis with complete heart block.
Okay, uh-huh.
So
So
he
you
had a
opened up.
left side subclavian stenosis, right side he
Yeah,
had a pump, and he had a complete heart block with LAD stenosis. So
okay,
the problem was he didn't have another access to put, and the guide wire has to keep from the left side for the pacemaker.
okay,
So we have done an SVC balloon.
yeah,
Then once the SVC balloon was done, we have done a pacemaker. Once the
yeah,
pacemaker, after the pacemaker, we have done an stanting, a lady stanting.
yeah,
After that, 3 months, first 3 months, he was on dual antiplatelets.
yeah.
He was on Linta, he was on clopidogrel and aspirin. And after 3 months, we have taken him for robotic kidney transplant.
I see. Excellent. Wow.
So we have hold
Very
the
good.
platelets. We have switched him to heparin.
Yeah,
Then we have the transplant.
yeah,
The drain was hardly any drain was there, and
right.
hardly the wound. And second day he was mobilized. Pain was pretty less. Wound is small. So it's easy for me to restart antiplatelets. So, so second day, once everything wound was good, drain was less. The next day I've started him on antiplatelets. So
Okay.
that's how we have within 3 months we have done a cardiac procedure and a transplant, and we have sent
Okay.
him home very well.
Very good. Excellent. Okay. Excellent. Yeah.
Yes, I think there's a question from Dr. Augustine.
So,
He
what are
said,
some of the modalities in maintaining post-kidney transplant patient with high output drain confirmed to be a lymphocyte? The drain has been draining for almost about 4 weeks. Okay, great question. So here, the same page one we had a patient where there was a big lymphocyte. You can try here. One thing is octreotide. You can try low dose of octreotide, where some studies are there where the lymphocyte get absorbed. But if the lymphocyte is not creating any graft dysfunction, if the lymphocyte is not creating any hydronephrosis, just leave it and try with, if the drain is persistently high, sometimes you can give betadine, occlusion. You can just put some betadine into it so that it will get sclerosed, or else try with octreotide. uh, these are the two ways where you can make sure like the lymphocyte gradually or drain gradually reduces. So you are mentioning drain is persistent, right? The drain is there still for 4 weeks. If the drain is there, yeah, yeah. So in these scenarios, try with octreotide. But and also, if the drain is there, just try to put in some betadine into it. And you can get some sclerosed, the at least like lymphatic we have seen where we have put in the betadine through the drain, and slowly it will get sclerosed. Yeah.
In this situation, surgically intervening at what stage roughly?
I don't see unless the thing is, unless there is a hydronephrosis, we don't intervene the
Okay.
lymphocyte,
Okay.
because again, the drain will be persistent here. So slowly sclerosing the thing with betadine or octreotide is a better option in these scenarios.
Okay. Okay. Thank you.
Try infusing betadine solution through into it, but make sure you put it aseptic precautions. Make sure follow all the aseptic precautions and do it. If you want any help, I can write a like how to get send that, how to do that. I can write and I can send to you, exactly.
Okay. Just if you can put your email on the chat box, Arun,
Yeah,
then
yeah,
we could
yeah,
help.
yeah. Just you can email me so that I can one patient we have tried with octreotide, where we had a good response. So you can try octreotide too. It's a subcutaneous, and you can try octreotide.
right, let me just recopy the email. I think it has gone to host and panelists. So let me just send it to everyone.
So
Just
thank
a
you for this.
minute.
Raising inflammatory markers and raising creatinine and urine lamp positive. Any possibility of urine lamp for the initiation of anti-TB? So urine lamp positive. Any specificity of urine lamp positive for initiation of anti-TB? I don't think so. I don't think so. We don't follow anything like that. And inflammatory markers, what markers she's mentioning about? Raising inflammatory markers and raising creatinine, urine lamp positive. Okay. Any specificity of urine lamp for the initiation of anti-TB? I don't think so. Nothing like tuberculosis lamp. We don't do anything like that. Till tuberculosis, we go with only sputum or tissue diagnosis or lymph node diagnosis, or any ADA levels of effusions. These are the markers we go for tuberculosis.
Right, thank you, Dr. Arun, for the response to those questions. I believe for any other further questions, you can use Dr. Arun's email that has been posted. The
Yeah.
question is on how can healthcare systems ensure equitable access to transplants, especially for low resource patients? I think settings, maybe. Yeah.
Okay, equitable access. See, the only thing is, see, only thing, an obstacle for any resource patient or low or high most of the time is the drugs. See, the surgery part, here in India, even in low resource settings like in government hospitals, we do free of surgery, free of post transplant care. But only thing here is the drugs. Compliance to the medications is an important point here. So most of the time rejections happen due to non-compliance. If the patients are taking medications, we hardly see rejections in this guy with this mycophenolate and tacrolimus. Your only thing is you have to talk with the government, go strong to the government, and represent from all the nephrology, and make sure the patient gets free medications. Because in our province here in India, all patients in low resource settings will get free medications lifelong. So that is the only way you give access to the patients, the transplant access in low income settings. Because doctors, we do free surgeries, we do free healthcare, but once they go home, taking medications is a challenge which has to be given free in low resource settings.
Yes, thank you for that. Indeed, I think it's quite important for us to have buy-in from the government and
Yeah,
also the people in leadership, just to subsidize this for patients and make them available. I believe I will close the part of Q&A for now. There are no more questions on the chat box. And if there are any, I believe the team members or participants should be able to reach out on email if needed. So on behalf of Africa Healthcare Network and our panelists, I want to convey my thanks, Dr. Arun, for making your time and giving us a very enlightening presentation. And we do hope that, of course, in future you'll come again, probably take us through more topics, especially the case-based approaches that most of our participants can learn from in these low resource settings. Thank you once again. I'll hand it over to
thank
Dr.
you.
Lloyd to close.
Thank you very much, Arun. I think that is a wonderful session.
Thank
And
you.
as we discussed, I think we should have some case-based discussions. It can be,
Sure.
with your students once in 2 months or something like that. If we can have a case-based discussion across the same, the only problem is the time. Some case-based discussions and how to tackle problems in transplant. That sort of a approach to various issues, rejection, graft dysfunction as such, and things like that. So that will really be interesting, immunosuppression management and things like that.
Sure, sure.
Practically,
Because
and hands-on
our
cases.
case, yeah, but each case, when we take a case, we can have a depth of each case discussion. Like
Yeah,
because I just summarized all these cases, but once we do it frequently, we can one case by case we can go and discuss more,
yeah,
like immunosuppression handling and everything.
yeah, sure. Okay. Thank you so much. And I'm
Thank
sorry we troubled you, despite not being
you.
ill. I didn't know. We could have always postponed it. I didn't know
Sorry, I
that
had
you were
a
not
cough
well.
and I was. I'm sorry. Yeah, thank you very much.
Thank you so much. Thank you very much. Keep in
Thank
touch. Thank you.
thank you.